Hi, everyone. Good afternoon. My name is Katie Cook. I am with Adirondack Health Institute and the North Country Telehealth Partnership. Welcome to the May Telehealth Learning Collaborative. Today we have a great presentation lined up, as well as a few other updates later on in the hour. I'm going to kick it off with introducing our speakers today. With us today, we have Dr. Stephen Leindecker and Joanna Loomis. Dr. Stephen Leindecker is the medical director for Fort Drum Regional Health Planning Organization and the North Country Initiative. He provides clinical leadership and serves as a liaison to healthcare partners in the region. He is also an internist and partner at Lowville Medical Associates in Lewis County. Also with us today, we have Joanna Loomis. She is the Deputy Director at the North Country Initiative. She works with clinical and community-based partners to design, implement, and monitor healthcare transformation and value-based contract initiatives in Jefferson, Lewis, and St. Lawrence counties. Today, they will be discussing telehealth transitional care management for the Medicaid population. And I'll turn it over to you, Joanna, to kick us off.
Great. Thank you for inviting us to be part of today's presentation. And thanks everyone for joining. It's great to see some good representation from around the state, as well as among different parts of the healthcare continuum. I know that there's a variety of attendees today, so we hope that this will be some way to each one of you. So just to kind of kick us off, you're hearing from us today because Fort Drum Regional Health Planning Organization, and really through its work with its partner North Country Initiative, has been working on a pilot project, and telehealth is a significant element of that. And so we thought it might be a fitting topic for today's collaborative. So let me advance to the next slide. You've already seen this. Actually, I will back up for one moment and just sort of give you a little more about our organization. So Fort Drum Regional Health Planning Organization is a nonprofit. We are a health planning organization. We focus on population health improvement projects. We really service a footprint that includes Jefferson, Lewis, and St. Lawrence counties, main primary service area in the state. And really born out of the fact that Fort Drum, the military base, is located in Jefferson County, and it's the division-sized post installation in the United States that does not have its own hospital. And so really we were born out of that, and our mission is to improve the system for health for all of the people that live in the three counties, including certainly civilians, but also soldiers and their dependents. And over time, our mission has sort of grown and evolved to meet the changing needs of the healthcare environment in the region. We partner very closely with North Country Initiative, which is so it can be a for-profit. We share office space together and have a shared staffing model as well. So North Country Initiative may be familiar to some of you on the call. We were the PPS for our region for DISRIP, and we also serve those same three counties. And our work these days really focuses very much on the value-based contracts that we secure for our partners, and then help manage and kind of monitor those contracts. So we have several active contracts within our region. So now that kind of gives you a little bit more context of why we're here, really today we want to talk about transitional care management. So this has to do with when patients are discharged from a hospital inpatient setting, and in some cases from an emergency department setting. Certainly when patients are discharged from those settings, there may be some particular needs that they have, and transitional care management is a very critical piece where typically primary care would sort of swoop in and then re-engage that patient and perform a mixture potentially of some clinical and maybe even some social screenings and services to support that patient in that really critical 1 to 2 week period after that discharge, to see what they can do to support the patient and hopefully prevent them from having a repeat hospital or ED visit. And so in our region, and really throughout the country, transitional care management has definitely been utilized among the Medicare population. That's the traditional version that we'll talk about. But we know that Medicaid patients also definitely need transitional care management. And so really what we've done is to pilot transitional care management to the Medicaid population. And we'll talk about all of that more in detail in today's presentation. And part of that is the role of telehealth. So how can we use telehealth as a tool in our toolkit to provide that transitional care management, which hereafter we'll likely just refer to TCM. So that's the gist for today's objectives. And we'll launch right into what is traditional TCM for the Medicare population. You can see here a typical sort of flow of a patient has been discharged from a hospital to their home or community setting. And then TCM sort of dictates that primary care should get that patient's discharge information, call the patient within 2 days, and then actually conduct a visit, which can be in office or through an audio-visual telehealth connection with a patient in their home within 7 to 14 days. The office then bills Medicare one of two codes, a 99495, which is used for moderate complexity medical decision making, and they've had that face-to-face visit within 14 days of the patient's discharge, or the 99496 code, which is a high complexity and having the face-to-face within 7 days. Dr. Leindecker, I'm going to invite you to kind of share what you would like about Medicare TCM, the traditional TCM.
Yeah, so from a clinical standpoint, one of the reasons we thought of using the traditional TCM is that it's been very well accepted by our providers, and certainly I think has been a success for our ACO. Providers, I think, find that their visits after hospitalization, at least historically, have been a bit of a thrash, that someone shows up, they don't have all their information. There's often loose ends, typically either test results not done or more likely medications that are all over the place, not reconciled, and you end up spending half, 2/3 of the visit just trying to figure that out. So what the TCM process has done, I think, in most of our offices is really simplified to some extent process from a provider standpoint, for sure, getting care managers or nurses in the first 48 hours to reconcile the med, make sure that you keep small problems, and really then allow the provider to focus on that very vulnerable transition. So we thought if it's kind of a win-win in terms of patient and provider satisfaction, let's see if we could leverage this and use this same idea in the Medicaid population.
Absolutely. And to kind of share a little bit more about our journey in our specific region and organization with this traditional Medicare TCM, we really started embracing this in 2018, when at that point, these codes were really not being billed very often at all by our partners. And so when we saw how effective this was in other parts of the nation, it really became an intensive effort within our accountable care organization, which has a contract with Medicare. And so you can see that in 2017, we were only, our partners were only conducting a TCM on 6% of those Medicare discharges. And that has increased over time to 36% in 2018 after we really made this an initiative, to 52% in 2019, and then back down a little bit to 50% in 2020. Although I would note that given the extreme challenges of 2020, I actually think having a 50% rate is sort of a win, knowing how difficult 2020 was. And our goal, really, ideally, we'd love to see TCMs be performed on at least 75% of eligible discharges. Of course, this is never going to be perfect, but that's kind of the goal that we're shooting for. As Dr. Leindecker noted, we often think of this as a win-win, and not just a win-win, but a win-win-win, really, for everyone involved. Patients, anecdotally, we know that patients tend to really enjoy this service, if you could say that. They like having their primary care very proactively reach out to them after they've been discharged to make sure that they have their medications reconciled correctly. I think that's probably one of the most confusing parts of being discharged from the hospital, is you have a whole new list of medications and you're not sure how that really works or jives with your current list of medications. So that's a huge function of the TCM, is it's a requirement that you have to really take a look at medication reconciliation. And then, for primary cares, I would note that TCM, those two codes, do carry substantially higher reimbursement than a normal office visit. And so, sort of as it should, because a TCM requires a lot more intensive homework, a lot of digging for discharge information, a lot of coordination, and multiple members of your primary care team are engaging in that work. So it is well received by primary care because it is reimbursing them adequately for that work that they're doing. I would also note that we've had several providers remark to us that really focusing on TCM has been one of the most professionally rewarding aspects of their career. When a physician says that to me, I don't take that lightly. So I get the sense this is a very rewarding part of being in the primary care space. And then, of course, for the ACO or any value-based entity or any entity that's looking to reduce costs, we know that patients who have a TCM after they've been discharged have significantly lower 90-day post-discharge readmission rates. You can see on the screen, we've experienced an average about a 4% reduction, and significantly lower 90-day post-discharge total cost of care by about $7,000. That is huge. And so if you are in a value-based arrangement, and you're looking at ways to reduce avoidable costs, well, here's a pretty obvious direction to go in. I would also note too that the previous slide that shows the arrows, it does simplify the process of a TCM, of course. I think one of the interesting parts in a timeline of TCM is actually the very first part. How do primary care teams know when their patients have been discharged from a setting? And so here's where our ACO in particular has harnessed the power of our local health information exchange. We get alerts as the ACO when any of our attributed patients experience a discharge. We actually clean those alerts up because, as any of you know who get these alerts directly, sometimes the volume is just a little overwhelming, and you get all sorts of information. You get admission, discharge, and transfer. You're getting, if they've been discharged from, a hospital to a skilled nursing, a hospital to some other setting. And so we do our best to clean those up so that we're feeding our partners directly lists of their patients who really probably do need the TCM. So we're not sending them kind of everything else and all that noise. Anything else you would add, Dr. Leindecker?
No, I think that's good.
All right. So as Dr. Leindecker said, knowing how well this has worked in Medicare, it was an obvious direction for us to apply the Medicaid population. What's interesting is Medicare, managed Medicare, and most commercial plans do pay for TCM, but managed Medicaid does not. So that's a sort of an obvious direction. We know how well it works, and we know that certainly the Medicaid population, with its assumed challenges by definition, patients with Medicaid are likely going to be fairly low income. We know that they are kind of butting up against some significant hurdles and challenges in really taking control of their health. And so they probably need the support, arguably, even more so than maybe potentially some of the other patient populations. So what NCI has done is we have a pool of funding that we were able to dedicate to piloting out TCM to specifically the Medicaid population. And we are just in the early stages of that. So that started in April 1st of this year. We will continue that through at least the end of this year. And it largely mirrors the Medicare TCM guidelines, but we did tweak those a bit to account for what we anticipated would be unique needs of the Medicaid population. So one big difference is TCM is only allowed for Medicare patients after they've been discharged from a hospital setting, but we know that the Medicaid population does have a fair amount of ED setting. And so we are allowing our partners to do the TCM after not only a hospital inpatient, but also an ED discharge. We also hear fairly frequently that it is a real challenge getting a hold of the Medicaid population. There's changing contact information that's experienced on a level and a scale that's much more frequent than many other patient populations. So we increased the initial contact requirement from 2 to 4 days. And here's a very salient point for this particular audience and presentation. We also know that the Medicaid population may experience more transportation or internet connectivity challenges than other populations. And so our primary cares can actually conduct that actual quote unquote face-to-face component, the face-to-face visit. They can conduct that one of 3 ways, really to be determined by the needs of the patient more than anything else. So if the patient is able to come into the office, wonderful. They can conduct that as an office visit. This sort of next best would be through an audio-visual telehealth connection. But if the patient does not have the technology or connectivity to do so, then we allow them to do a second audio-only phone call. So that is a significant kind of piece there to note. And then the final big element, which could be its own presentation, is incorporating a social determinant of health piece. So again, we know that, we anticipate the Medicaid population has significant social needs. This SDH has been a buzzword. I think everyone on this call has heard it many times, but when it comes to actually moving forward and doing something in that space, our region has been a little hesitant to do that. We hadn't actually fully implemented a standardized SDH screen. And so we really felt that this was the time, let's do it. And so as part of an MTCM, which I should know is our term for a Medicaid TCM, and Dr. Leindecker, his patent, copyright is pending on that. He came up with that. So in order to be paid for an MTCM, our partners have to not only conduct sort of the standard elements of a traditional TCM visit, but they also have to administer a standardized SDH screening tool. And then if the patient does have needs identified through that tool, we ask them to code those needs appropriately using Z codes. so we can better track that on the back end through claims. And then also, of course, conduct appropriate referrals to community services as needed. What would you add to that, Dr. Landecker?
So yeah, that's very good. I think once we open this up to the emergency room discharges, then that ups the ante in terms of volume and the amount of alerts we're going to get through. Probably most of us will use the care manager since they're the ones typically in our offices who function in that regard. What again, as was Joanna mentioned, this is literally 6 weeks out, so it's we don't have a deep knowledge yet of exactly what this is going to look like. That being said, what we've done, and I think what other offices have as well, is we're trying to triage a little bit those folks who have been in the ER and try to figure out if this is someone really who might benefit from this deeper dive into, SDH screening, into, a follow-up appointment to review, medical or non-medical issues. Again, this often is not necessarily a medical problem. This isn't a congestive heart failure patient who keeps going into the emergency room. This may have other elements. So we're trying to, I think, triage a little bit those who are more appropriate for this process. We purposely left it fairly broad to make it a little bit more organic as we learn about what offices are doing, how they're finding this process, what patients and staff are finding. We left it a little bit broader to begin with. I do think that using the questionnaires and asking SDH questions is an art. They're fairly intrusive questions. And so we want to be selective. We certainly don't want to be off-putting or, come off as condescending or anything of that nature. So we're trying to kind of navigate this a little bit within our populations and primarily identify those people who have been high utilizers and figure out what it is and why is it that they are utilizing, and then try to resource them with appropriate services, which may well, and in fact, I would bet many of those services are not going to be within the context of a primary care office. Community-based organizations likely are more adept and able to fill those needs. So it's going to push us as a region, I think, to develop those trusted relationships and also to develop that kind of closed loop ordering, that feedback that we get on a regular basis as if we referred someone to a neurologist. So there's a lot of layers to this that we're still working through. I think the telehealth piece is helpful in that it's just allows us easier access to the patient right from the beginning. And I guess that's leading us in. But I do think that providers in general have become a lot more comfortable using telehealth. And honestly, patients are going to demand it. It'll be interesting to see once the pandemic is officially no longer signaled that by the World Health Organization. We'll have to see where these reimbursements go. But I think we've already used the telehealth feature to the MTCM, and it's working fine. And in fact, my guess is it'll work better in some ways than the standard TCM.
Thanks for that. Yeah, good points. And as Dr. Landecker kind of segued into the telehealth space, again, knowing this collaborative is focused on telehealth, we wanted to highlight the role that it really can play in transitional care management. And so just to kind of lay it out in a clear fashion, transitional care management, those two codes for Medicare, they've been telehealth services since before the pandemic. And for both of those codes, again, there's kind of two main components, two main patient-facing components. One is a first interactive contact within 2 days. The second is a face-to-face visit within 7 to 14 days, depending on the complexity and how you're coding this. But that first interactive contact really is almost 100%, I mean, accomplished through a phone call anyway, which I would argue is, the form of telehealth, right? So that was already, part of it. But the face-to-face encounter, again, pre-pandemic, pandemic didn't actually change this. That could be in person or through an audiovisual connection with the patient at home. And Medicare does not allow an audio-only connection to satisfy these requirements. I would say that pre-COVID, and Dr. Landecker, chime in if you have a different perspective, but my assumption, my understanding is that the vast majority of our partners anyway really never utilize the telehealth for the face-to-face encounters. I mean, there may have been isolated instances, but for the most part, TCM is really done in the office. Would you agree with that? Okay.
Sorry, I was on my mute button. Yes, I would. Yeah.
Okay. And we'll talk a little bit about how, COVID has, altered that a bit. But, we purposely designed MTCM, so the TCM for the Medicaid population, to be even more friendly to a telehealth approach. Because, again, that first interactive contact, pretty much 100% of the time, that's going to be a phone call. And that second contact, as we noted earlier, again, you have 3 options this time. You can do the in-person visit, you can do an audio visual, or you can do an audio only. So we really tried to make that as friendly as possible. And again, more based on the patient's needs than sort of practice convenience. We really, I think our consensus and our understanding is that when there is some sort of actual true face-to-face component that you get with an in-person or an audio-visual connection, that it might lend to a more effective, more meaningful interactive contact. But we'd rather see someone have a second phone call than nothing at all. And we recognize that there are plenty of situations, particularly with the Medicaid population, where a phone call is all that's feasible. So we get that, and we wanted to make that an option for them. Anything else you would add, Dr. Landecker?
No, not at this point.
Okay. So really, here's kind of our last real slide. Just where do we stand? Again, we're about 6 weeks into this, so we're very fresh by our own admission. We're very early on into this. We don't have a ton of data for you to show the MTCM sort of return on investment, but we can kind of share a little bit of our experiences. I would say TCM for the Medicare population, again, pre-pandemic, telehealth wasn't really utilized much for this. During the pandemic, I think it was utilized definitely more by some practices and settings more than others. And from my perspective, I would say that maybe the smaller independent practices were just more nimble and agile in really embracing telehealth for TCM during the pandemic. I think maybe some of the larger systems, it's just harder to kind of really quickly adapt to those changes in some cases. And so I know just anecdotally, at least a couple of partners who were, again, that sort of independent physician practice that ramped up within a matter of a couple of days, and they were doing telehealth for a variety of visits, but they also implemented this for TCM as well. And then, post-COVID, I'm not sure. I personally hope that, our partners can, incorporate telehealth for TCMs. I think it makes a lot of sense in certain cases. Again, we list here some things: patient convenience, I know there's a number of patients that they're able to do it and they would prefer it, especially in the winter months when there's a couple feet of snow on the ground. That's definitely a consideration. And Dr. Lendecker noted when we were preparing for this that, COVID-19 positive patients who were released from the hospital, a clear advantage using telehealth for those patients as well. I think there's still going to be some work done in terms of, EHR integration, how we really continue to flesh that out. And of course, providers just continuing to be more and more comfortable with using telehealth. What would you add to that, Steve?
Yeah, I think it's on both ends. People know that it's happening, have friends or have experienced it. I think honestly, there's going to be a pretty big demand. I think this is a launch for telehealth in many respects. So it'll be interesting to see kind of what happens in the future. And then, um, post discharge, depending, I guess in some ways, I think providers really like to get a look at people and see kind of how they're functioning, what they're doing. But there's clearly a role for a fairly early telehealth visit followed by, an in-person. So timing is everything. And if we have the options available, I think the barrier, the barrier on the provider side, I think is gone. So we're pretty comfortable doing this sort of evaluation. So then it becomes really what's the most clinically relevant and appropriate thing to do. And that certainly was not the case pre-COVID. So it's opened some doors, and even old, grumpy, cynical docs like me can, learn a few new tricks. And I think that's what's happened.
Thanks for that. And I think specifically with the Medicaid population with MTCM, again, a little too early to tell. And we are meeting this month with all of our partners and just sort of touching base with them on how the MTCM process is going for them. So far, I've heard, and as Dr. Lendecker alluded to, the specific component of conducting that social determinant of health screen is a very sensitive one. And I'm finding that so far, partners that are implementing that through a phone call, like doing that during a phone call, say with a care manager, that it's a very awkward experience. And that partners have tended to have better results when it actually has just been like a piece of paper that they fill out in their car while they're waiting to come in for an office visit, or something that they're filling out in the waiting room. On the surface, that feels like a more a less personal approach, but I think sometimes that's almost easier because the patient can just be alone with the form and fill it out. Of course, if there's literacy issues, then that needs to be navigated some other way. But we're learning how to approach that SDH piece, and then how that fits in with telehealth. If a patient isn't able to come in for an office visit, how do we effectively deploy that screening tool in a way that's actually helpful and, again, non-intimidating and patient-friendly in a non-invasive way? I would share kind of just on a quantitative level, just what the volume has been, just to give you a sense. Since April 1st, when this pilot began, we've seen about 650 ED discharges for our patients who have Medicaid and are in one of our contracts that we're following with this. So again, 650 ED discharges and about 120 inpatient. That definitely underscores our feeling that, our patients, our Medicaid patients, were really having a much higher interaction with the ED than inpatient. And kind of by comparison, we can see on the Medicare side, which again is the traditional TCM, we've seen about 330 inpatient events. So sort of as can be expected, the Medicare population, which is by definition maybe a little bit older, may have disabilities. They are going inpatient much more than a comparative volume of patients who are, just have Medicaid and have, again, by definition, really tend to be a younger population, but they have, lower income. So those are our numbers so far. I would also share that meeting with some of our partners, they've remarked that, well, I didn't do the MTCM on patient X because they really only went to the ED because they cut their finger or they had a fever. And we've almost kind of said, we've pushed back a little bit with them on that and said, actually, this is an ideal time to do an MTCM. Go ahead and do it. Get paid for it. Sure, it's not going to be a complicated exchange with the patient because it was a very straightforward event that landed them in the ED. But, take a look at the patient and the situation, and this may be a really ideal opportunity to engage with them and remind them, hey, what time did this happen? We either our office was open, number one, and we maybe could have gotten you right in right away if it's something that we could handle, or two, maybe it was after hours, but we have an after hours, call service. We could, next time, if anything like this happens again, we can help you triage it. We're open 24/7. And, maybe we can avoid you going to the ED in the future. So we do know that this population does have a fair amount of, they're kind of quick to go to the ED sometimes. And part of this is, in some cases, patients who may not be incredibly socially or clinically complex, but they just need to be reminded, call us and we can probably help you out and avoid you that ED visit to begin with. So that's all I have. Dr. Leindecker, anything else you would add to that?
No, I think just opening it up to questions. The piece about how to deal with those, relatively simple ER visits. I think that's another area that we're going to need to explore as we work through the MTCM process. But there's certainly an educational opportunity as well.
Mm-hmm. Yeah.
All right. Thank you both so much. A few questions did come in, so I'll get started on those. And again, if you think of anything, please put it in either the chat or Q&A. The first question is, under this self-funded pilot, are you contracting with an existing organization who currently operates TCM for other populations, or is this a new program under NCI?
So if I understand the question correctly, we're sort of NCI through our accountable care organization and our independent practice association, which are two independent contracting entities, that one of which contracts with Medicare, the other which can contract with any other payer and does hold several contracts with managed Medicaid. Those entities already work with our network of primary care practices to conduct transitional care management for the Medicare population. So this is really just kind of opening up this opportunity for them to do so with the Medicaid population. So we ourselves at NCI, our staff does not actually do anything patient facing. We're not doing any of this work. We're just sort of in the background helping to coordinate and facilitate this work. Does that answer the question? I don't know, Katie, do you think that answered what they were asking?
I believe so, yeah. All right, the next question is, do you connect clients to Medicaid health home care management when they're eligible? And if so, how does that handoff work? Does the MTCM care manager not get involved?
Yeah, so that is a question that we actually got when we released a press release about this when we were going live, and we immediately had several health home entities reach out and say, can you tell me about the role of the health homes and all of this? Yes, I think there's work to be done though. So the way we see it is health homes are great for, those Medicaid patients who need maybe some longer term support after that intensive, 1 to 2 week post-discharge period ends. So again, remember, TCM is really focused on a very short period of time, the couple weeks after a discharge. But certainly when our partners are working with patients and they identify that a patient is going to need some support after that 2 weeks, our partners do generally know about health home care management, and they generally know how to refer. But I will be the first to admit that there is continual opportunities to re-educate and work with our primary cares to really make sure they truly, really get how useful that service could be. And so we do conduct care collaboratives, they're called, where we basically help convene care managers. They could be CBO care managers and also primary care managers. We get together every 2 months. We talk through kind of topics that are relevant to them. And on our docket for this month, it's actually later this week, is health home. And so we'll be revisiting what are health home services, who does them, and how can you refer.
Okay, thank you. The next question, it may have been mentioned, but what platform is used to communicate with patients, and how and at what point is the appointment established?
This is a really decentralized process whereby really it's whatever platforms and methods our individual partners utilize to connect with patients, that's how they would connect. So the centralized piece is us as the ACO and the IPA. We get information when any of our attributed patients are being discharged. We assemble that, package that on a daily basis, send out those notifications and alerts to our primary care partners. So let's pretend I am front desk receptionist at practice A. I get, a secure email from the ACO that tells me that 3 of my patients have been discharged today from the hospital and or the ED. I then work with my team to contact the patient and arrange. So just like any other kind of appointment, it could be, okay, patient number on file is this, someone from the front desk or a care manager calls the patient and, decides, can the patient come in within 2 weeks, or is that not feasible? If they can, then they arrange to schedule the appointment. If they can't, then they would, utilize whatever telehealth platform that the practice uses to conduct that visit. Dr. Lane-Decker, anything you would add to that?
Yeah, we've pretty much let that up to the individual practices. Some of the more sophisticated EMRs obviously have a kind of integrated telehealth platform, which is great. It's also expensive. Surprise, surprise. So many of us have kind of like basically our practice uses DoxyMe. It's relatively straightforward and simple. One thing I would reiterate too in terms of the health home question is that for care management, kind of capital C, capital M management in general, I think most of our entities within NCI have, for the most part, kept that in-house. And we haven't had a lot of outsourcing of care management. So I think the providers have liked that in that they can keep tabs a little bit more on what's happening to the patient and where and why, either via their care manager or, some kind of more integrated or shorter feedback loop. I think so this area has not really ever had significant managed care, like 1990s, early 2000s kind of thing. So we're just kind of learning that now as a region. And I think it's been helpful to reinforce some of the relationships with the community-based organization. I think for sure DISRIP gave us the introduction and allowed us at least name recognition. And we're hoping that projects like this really start to establish working relationships. And if that can be supplemented, augmented, or reinforced by health homes, that's great. But really, at least, I can speak to a very small community where I work. We need to we don't have a lot of choices in terms of what community-based organizations we use. And of those, we really have to have a fairly active dialogue and make sure that we're getting feedback fairly routinely on our patients so that we kind of know where things are at. And it's not necessarily that the providers need to steer it, but I feel really that if the office has a care manager, that care manager really is kind of the person who's the captain of the ship to some extent with this MTCM process. So it's a little bit, it kind of demedicalizes I think or decentralizes it in some ways, but it still remains in the context of the primary care office.
All right, thank you. There are a few more questions. Do you use a referral platform to meet the needs of the patient with community partners?
Great question. No, we do not, although we're aware of several. Unite Us comes to mind, certainly, and there's others out there for sure. I guess we're taking the approach of just trying to do this in a very simple way. Going to identify ways to improve on this as we go along. We just shy away from investing a lot of money into something that, there's maybe underlying kind of other needs that we need to tackle. So short answer is no. What we've done is we've kind of through the work of DISRIP, when we naturally put together an inventory of community-based services anyway, we've taken that and greatly consolidated it and really tried to turn it into like a 1 to 2 page kind of document that just actually mirrors our screening tool. So our screening tool is separated into sections. It was developed through a template that was provided through the American Academy of Family Physicians. We adapted it in very minor ways to our needs. So it has kind of overarching sections about like housing and food and nutrition and personal safety, etc. When a patient screens positive for any question, we give the practices kind of like a cheat sheet. It tells them, here are some Z codes that may align with these needs. Choose them as appropriate. And then also, here's this inventory of services, again, grouped according to those needs so that if a patient screens positive for one or more, they can kind of just reference that inventory, and at a glance, they can see which counties these services serve and, just basic contact information, just so the main phone number, and then the care manager or whomever, but in all likelihood, the care manager in the practice would then actually conduct that referral. Is it more maybe laborious in terms of, staff time? Yes, there is no shiny platform that's kind of doing this work for them. But I would say that in our region, we have the benefit of being a little bit smaller and a little bit naturally kind of deeper connected. And so, oftentimes our care managers, they're certainly aware of some of the services anyway. It's a nice benefit to have it on a piece of paper because they can't keep everything in their heads all the time. So there is a list for them to reference that hearing so far anyway has been helpful. We may go through a platform at some point in the future. We're just not there yet. Dr. Leindecker, anything you'd add? Okay, he's saying no.
All right, and we have one more question. In raising the use of TCM from 50 to 75%, what are the challenges on the patient end?
I think whether it's Medicare or Medicaid, contact information is sometimes a hard thing. Contact information changes, and the practices don't always have that information completely updated. And it's the kind of eternal age old stuff of rescheduling, patients no showing. And there's a whole world of reasons for that, some of which are you could argue are actionable, and some arguably not so much. That's why we kind of set our goal at 75%. We know that we're never going to get 100%. But 75 felt like the right balance to shoot for. And some discharges really don't warrant a TCM or an MTCM, like Dr. Leindecker shared. Some patients, I feel like this is the kind of service that is fairly kind of easily communicable to say, hey, I see you were just, in the hospital, or you were in the ED. We'd like to bring you in for follow-up. Most patients, they're fine with that, I think, but there's some that don't feel it's necessary. I'm going to turn it over to Dr. Leindecker, though, because he's patient-facing and he probably has some more input on this.
Yeah, in terms of, I think in terms of the patient side, they, I would say almost uniformly welcome the phone call, unless, of course, they think we're a Medicare scammer, which is a whole other, oh, I could go on for hours on that one. I think they welcome the phone call. They like kind of crossing the T's, dotting the I's, making sure things are the way they should, and being able to ask questions. At the same time, sometimes during, this whole process, quite honestly, they're just sick of seeing doctors and nurses. They just want to rest and stay home. So that's number one. And then there's ones that are kind of tweeners that they may not really need to come in. And so that's the piece where some patients are saying, hey, do I really have to come in? I feel like I'm doing well. This was mostly a surgical admission, or something that doesn't necessarily relate to my chronic needs. I think often there are issues that when people come in, you address and can discuss, but there is a little bit of hesitancy. And certainly during, COVID, I think that's the exact population who really didn't necessarily want to come in the first place. I don't think there's a lot of other barriers for TCM, just depending on debility. I mean, some people are just really frail, and that going out, to physically go to a physician space is overwhelming, and hence, why the telehealth option, I think, is, a saving grace in that group.
All right, well, there haven't been any other questions, so thank you again, Dr. Leindecker and Joanna, for this presentation. I, of course, will be sending the slide deck out with the follow-up meeting notes, although there aren't a whole lot of notes. A couple of updates from my end. There is an upcoming telehealth conference that I wanted to share information about. I'm going to throw a link to more information in the chat. But the Northeast Telehealth Resource Center is holding their annual conference this year, and it will be in person in Manchester, New Hampshire, on Thursday, September 23rd and Friday, September 24th. They are currently seeking presentation abstracts. So if you go to the link that I put in the chat, you have until Friday, June 25th to submit an abstract if you're interested in speaking at that conference. I also placed a number of upcoming telehealth webinars in the meeting agenda, so be sure to check those out. There's an upcoming CMS Rural Health Town Hall this Thursday at 4 p.m. So certainly give that a Google and check that out. And then lastly, there was a recent update from the Department of Health and Human Services around new buprenorphine practice guidelines and expanding access to treatment for opioid use disorder. So in an effort to get evidence-based treatment to more Americans with opioid use disorder, the Department of Health and Human Services released new buprenorphine practice guidelines that remove a long-time requirement tied to training, which many practitioners have cited as a barrier to treating individuals. So, the practice guidelines for the administration of buprenorphine for treating this opioid use disorder provide an exemption from certain certification requirements, and that includes practitioners utilizing the exemption are limited to treating no more than 30 patients at any one time. Under this exemption, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and certified nurse midwives are required to be supervised by or work in collaboration with a DEA registered physician if required by state law. And this requirement does not apply to practitioners who are employees or contractors of a department or agency of the United States. Practitioners who do not wish to practice under the exemption and its 30 patient limit can get a waiver or seek a waiver. And this exemption applies only to the prescription of Schedule 3, 4, and 5 drugs or combination of such drugs. So I put a link in the meeting agenda for more information on that for those who are in this space and want to look a bit more into it. Our next telehealth learning collaborative will be in July, specifically on Monday, July 19th. Same time, third Monday of every month from 2 to 3 p.m. We will, of course, get an agenda out several weeks ahead of time. If anyone on this call is interested in speaking at a future telehealth learning collaborative, please reach out to me. I'm going to put my email in the chat, kcook@hihealth.org. And if you guys have any follow-up questions or want to be linked to either presenter, please send me an email and I can make that connection. If there's nothing else, we'll wrap up a few minutes early. Have a wonderful rest of your week, everyone. Bye-bye.